I have a question for all of you, just along those lines, and this is about what you had mentioned when you said ameliorating side effects. All of you treat, prescribe, you conduct phase 1, phase 2, phase 3 clinical trials, and I'm wondering if all of you, each one of you, would consider how you then ameliorate, try to prevent, or minimize not the side effects of nausea or weakness, but the real heavy side effects that a child then must carry forward for the rest of their lives, such as problems with hearing or possibly some cardiac problems. If you could say something about that. Thank you.
There's only one way. It's cut back chemotherapy. Now, why do I say that? Well, because I think many of the protective agents, chemoprotection or radiation protection agents, you always wonder whether they actually protect the tumor also. And there's a certain unknown until you do a randomized trial in neuroblastoma to make sure that whatever drug you're using is not hurting your treatment. Although in some other tumors, these drugs have passed the test. They do have protective effects on the marrow or body and not affecting the efficacy, but not in neuroblastoma. There's never been any randomized trial to show that these agents are actually safe. So the only way you can do this is to cut back therapy, is to keep cutting back on the chemotherapy. Now everybody does different things. You can try new agents, maybe that you can use up front, and maybe cut back some of the standard agents we have, like for the cough. You're cutting back on the Adriamycin by using topotecan, which obviously will hopefully cut back the cardiac toxicity. What we've done is to cut back this cycle of chemo. We went from 8 to 7 to 6 and to 5. And we stopped at 5. And you can say, well, why not continue? Well, we may continue to cut back to 4 and 3. And indeed, in some patients, you may not need all 5 cycles. So I think that there is going to be a moving target again for the next 5 to 10 years. I suspect that some patients may need 5 cycles of chemotherapy. By cutting back chemo, you are going to reduce side effects.
In the relapse setting, with the stage 4 poor prognosis relapse 2 months after the initial transplant, so pretty much multiple relapses every year, 7. So cisretinoic acid, then phenretinide, then cyclotopo, then cisretinoic acid again, monthly for another 9 months, or irinotecan ADT. If you get the kid down like each year to almost no disease, so we're talking 6 years of drug therapy, never once, not a day on therapy, but you can almost get him to being good. Would you consider myeloablative therapy with stem cell transplant, or would you consider the route I've gone, just try to do the least to, so you're buying time and see what happens, but when you get into a good state, would then you say, okay, let's see what we'll kill him, maybe we'll let him live, like maybe we'll cure him, or would you just carry on like I've been doing, sort of slow, every year it relapses pretty much same time of year?
I think that you bring a pretty important point up, and that is, can we actually fix that, and would actually a myeloablative transplant be the fix for that? We know, and we have good evidence, that myeloablation, high-dose chemotherapy, stem cell rescue, has benefit in the diagnostic, or in the upfront treatment. And certainly it's been tried again in the relapse setting. I would not say, though, that it would be a cure-all treatment. And so whether or not she got the disease down to a minimum amount or not, I don't know that that's really going to be a beneficial treatment. I mean, the question there is, like I pointed out earlier, it is the maximum of dose intensification. If a child's already gone through that one time, and you're able to control and give a normal quality of life with drugs that are not so invasive, there's not really clear evidence that putting a child through that kind of invasive therapy is going to provide a cure. Whereas there is the risk that you're going to have toxicities, that you're going to prevent that child from being able to receive other treatments. So anytime you take one, you run the risk that you may not be able to get others, or that you may have side effects that prevent you from getting others. You know, I think having 6 years of treatment without, or 6 years of relapse therapy, and still having a child with you is just an astronomical and wonderful thing to have. And you know, I'm sure that you count blessings on that every day. I don't think, though, that necessarily going back the old way is going to be the curative treatment. Now, if there were a regimen that were on an investigational study that seemed to be different than what he'd gotten before, or she'd gotten before, that made some difference in how the tumor was being interacted with the body, it would sort of make sense, because then there would be you would be facing the same sorts of resistance that the tumor's already developed.
I've often heard that, to try to view neuroblastoma as a chronic disease, that not necessarily as something to be cured right away. In that respect, and along with her question, are there any possible clinical trials for maintenance therapies, long-term maintenance therapies, instead of, doing the chemotherapy and then waiting for a relapse?
So I think that those are the types of things that many of us have talked about. An example, again, is the retinoic acid that we've used after transplant as that was a very important study that Pat Reynolds was involved with, where we were able to show in a randomized fashion that patients that did get this maintenance oral retinoic acid, and it was published in '99, I think as many of you are aware, did indeed prolong event-free survival and improve event-free survival. So we're always in the process of trying to figure out what other types of easily to deliver therapy that has relatively little side effects, that can be given as an oral agent, perhaps, that won't interfere with quality of life and cause any kind of significant toxicities. What else we potentially could tag on, after consolidation, knowing that there are, unfortunately, a substantial number of patients who will develop recurrent disease. So yes, that's certainly something that everyone's very interested in testing. As I think many of you know, currently within the COG right now, we're combining retinoic acid with antibody therapy as a randomized study to see if immunotherapy combined with the differentiation agent will improve outcome for patients who have high-risk disease. And we anticipate adding in additional post-consolidation biologic-type therapies in future studies. But you have to complete a study to then, test another agent. But there are a number of agents that we were thinking about potentially integrating, and absolutely might be that anti-angiogenic therapy would be a great thing to tag in there at the end. There are other biologic agents that might be, very good to kind of cassette in post-consolidation. But when there's this evidence of that, clearly there's a substantial number of patients that have this minimal residual disease following consolidation, we need to come in with something different to hopefully effectively kill the residual cells.
I just have a question about stem cells and the storage. For those children who have stem cells left after transplant or whatever it may be, where are they stored? Are they stored at your hospital where you were treated at initially? And how long? I was told that they are kept for 5 years and you have to pay for storage after that. And how does all that work? How long do you suggest keeping those in storage? Lifetime? Is there a year mark? Kind of help me out on the storage of your stem cells.
They're stored at your institution where they're collected at, and at least in my institution, I haven't heard that actually you have to pay after 5 years, so maybe it's your institution, but I actually haven't heard that on this. Yeah, I know that there are institutions actually, because of the number of stem cells frozen away being so large, that their freezers are getting so big, they have to start charging. Now, I think coming back to the idea of, let's say in fact someone is 5 years from transplant, first of all, the risk of late relapse obviously still there. It's not that it's completely gone, but if someone's okay for 5 years, I think that's a pretty good guarantee that hopefully nothing will happen. But more importantly, in 5 years, your child is at least double in size, if not more. Now, as the weight gets so much, get bigger, the marrow or stem cell that's stored away is not going to be adequate anyway. You really cannot use it. The number, proportionally gets so much slower. So that stem cell essentially is no longer, after a while, when the kid is so big, to be really useful for anything. So I think that there are some, at least institutions might say, well, why even bother to keep it? If you want to keep it, you can pay for it. And I think that, that's sort of the rationale why some institutions ask for the investigator at least to think, long and hard why you want to store to keep the marrow or stem cell there.
As a follow-up to that, to the stem cell question, with kids who have relapse disease or even kids who have refractory disease, the number of treatment options that are out there that potentially could use a stem cell rescue, are we getting enough stem cells up front? Should we be getting more up front? Should we be storing more? Understanding that as time goes on, I understand the proportional problem as they get older and bigger. And I know Dr. Cohn, you've written on having cells for the rainy day. These rainy days are getting longer and farther apart, thankfully. And do we need more?
Yeah. So, I'm a huge proponent in collecting stem cells up front with the knowledge that there unfortunately is a chance that your child may relapse and may require some therapy in the future that will require stem cell infusion. We've got a number of protocols out there in the relapse setting where you get the agent and it requires a stem cell infusion just because the agent causes myelosuppression. So certainly at my institution and what I recommend for families is that when the stem cells are harvested, that we do collect extra for a rainy day, and we do store it away so that if indeed patients do need to have a relapse protocol that requires a stem cell transplant, we have those stem cells available. I always like to be prepared. It's sort of like having insurance. And if you collect them and you don't need them, great. But I would rather collect them, have them frozen and available so that if you need them, you've got them.
My granddaughter was diagnosed stage 3, unfavorable cell, unfavorable gene, in July of 03. She relapsed in 05, July. We were here a year ago, and in August, her MIBG showed uptake in her chest cavity where it relapsed the first time. We started giving her something called mangosteen juice in September, and in October, when they did another MIBG, it was gone. Has there been any studies done in this country about effects of mangosteen juice in neuroblastoma? I know there has been some done in other countries.
I've heard of it before, but as far as I know, there's not been a direct clinical trial to see the effects. And it's fortunate that your granddaughter had effects from it, or that the MIBG, which was positive before, became negative. I think that we're going to have an entire discussion on complementary and alternative medicines, and kind of the approach that I take with my own patients. When there is a drug that we know has benefit to the tumor, we should choose that drug. When we don't have a drug that we know has benefit, I think that there's a lot of different options available out there. But whatever drug you choose to give your child, whether it is something that's prescribed from a physician or that you get from another location, they all have side effects. So just saying that a drug or that something is an alternative medicine doesn't make it safer, nor does it make the data, nor does it eliminate the need for appropriate data of that patient in that particular tumor. So just because an herb or a drug has some, what is the word? Where someone else responded at some point, doesn't necessarily mean that it's appropriate for everybody. And some of those drugs do have significant side effects. So if you're putting your child onto something, especially in conjunction with with a clinical trial or with agents that your physician is prescribing, you need to talk to your physician about what you're giving your children, because they do interact. They are drugs that you're feeding your children, and they do interact with the drugs that we give. And sometimes those interactions can be quite problematic. We did have a child on one of our clinical trials who had development of some liver toxicity, generally because of the interactions between the homeopathic medication the mother was giving and our chemotherapy. And when we look back to the literature, other children or other adults had gone into complete liver failure using that same homeopathic. And it sounds great, but just talk to your physician about it.
Hi, going back to the stem cell question. You've got a child that's been no evidence of disease. Do you, in 2 or 3 years, collect stem cells again, so that you've got another 5 years out of stem cells? I mean, do you collect those periodically to keep a child a fresh supply, or is there only one time that you can really get those?
No, physically, you certainly could get stem cells whenever. I just think that if you have a child who's doing well 3 years following therapy, the likelihood is the child will continue to do well. So it makes the most sense, I think, to collect the stem cells when you're initially collecting the stem cells, and to get a little bit extra and have it sort of way. I certainly wouldn't put a child through who's doing well in remission through a procedure of putting another line in and the whole rigmarole of what needs to be done to collect stem cells just to collect them.
I think, Sue, just to add to that, I think many of us as oncologists and transplant physicians have seen that the best time to collect is really after that second or third cycle of induction therapy. And that when you start collecting stem cells after 6 cycles of induction, after 6 cycles of induction and 6 rounds of topotecan cytoxin, after transplant, the viability of those cells, the quality of those cells to regenerate, good platelets, neutrophils, and so on, isn't as good. So the best time is the question that was asked earlier from Dave Bedezza is, should we be collecting for a rainy day? The best time is to collect up front, that second and third cycle. In fact, I run into many families that will come to us for transplant consults, and they've now gone through 8 cycles of induction. They've never been collecting it because they're still bone marrow positive. No, I'd like to see what everybody else thinks, but our take is still try to collect at the second or third cycle. That's when you have the most viable cells. And make sure, as a parent, you always want to know, how can I tip the scales in favor of my son or daughter being cured? Well, you tip the scales by going into things with as many cards as you can in your hands. Well, the way to get as many cards in your hands is to get as many stem cells as you can. And then make sure those stem cells are tested either by immunocytology or by tyrosine hydroxylase, some testing method to make sure that they're cured.
Right, and the other, in addition to potentially not being as good of a stem cell after so many cycles of chemo, we always are also concerned that they may actually be damaged somewhat by all the chemotherapy, and it actually may be that you're infusing stem cells that may actually be leukemogenic, for instance. So that's the other reason that we've moved the stem cell collection up after 2 cycles of chemotherapy in most of our COG studies. And for the most part, when we test them, because we test stem cells to make sure they're clean, the vast majority of stem cells appear to be clean, at least by the techniques that we're using right now in immunocytology.
I guess this is another question / commentary. How can we effectively communicate to treating hospitals where you have physicians that have a philosophy that the stem cell doesn't, if your marrow isn't clear, that they shouldn't collect stem cells? So what happens is, because of that one physician's philosophy, the kids are not harvested, and to mirror what Dr. Yannick said, they're not getting enough cells, or their cells might not be good. And we're kind of rogue in our initial treating, in our initial treating hospital, because we've been very, very critical and in a positive way, and we want to make it a better institution, because our ship has sailed, but yet we know that there are kids coming in port every day, and we need to make sure that that treating hospital knows what the standard of care is. I mean, the tip-top standard of care, there's different philosophies at different institutions. When you have kids coming in, they're not getting harvested soon enough because of a philosophy of physician who references and says, well, there's no papers written. There's no, I haven't seen it. And you just want to scream. I mean, I'm the mom, I'm not a physician, and yet it's, Bueller, where are you? I mean, it's just, why can't you do this? How can we, as a team, clinicians, yourselves, parents, get out there and communicate to the medical community that they're not doing it the right way, and it's continuing to happen today?
Well, one of the things that I think that we hope is that virtually all the institutions in North America, Sloan Kettering has their own institutional protocols, but the other institutions are largely members of COG. And if the institutions open up the COG trials, and if parents are offered COG clinical trials, in addition to being offered what we consider to be state-of-the-art care, they're also, if you follow the protocol, even if you don't happen to be someone who's particularly devoted their life to neuroblastoma, the people who've written the protocol have. And these are experts in the field who are part of the protocol committees, and what we hope is that by following COG studies, not just for neuroblastoma, but for other diseases as well, patients will be receiving what we consider to be state-of-the-art care. And on the COG studies, we write in there to collect the stem cells after cycle 2 of chemotherapy. And we have clearly stated it has nothing to do with what the bone marrow shows at that period of time. The important thing is to test the stem cells to make sure they're clean. Now sometimes you will rarely collect a stem cell harvest, and there will be contaminating tumor cells that you can detect by our tests. And clearly you don't use that harvest to infuse into the patient, and then you do have to give another cycle of chemo and try to collect it again. But I think for institutions across the nation that participate in COG, and parents who are willing to participate on COG studies, or at least follow one of the clinical trials that's considered standard, then you will be receiving treatment according to what the experts in the field believe is the appropriate treatment for that particular period of time. As Nikon said, it's always a moving target, and certainly as we learn more, we learn different things at different periods of time. And there was a time when we were using bone marrow, for instance, as a source of our stem cells, and that was a much more dirty place to get stem cells in the bone marrow than the peripheral blood. So as technologies changes and we learn more, we will make modifications to the protocol. I think many of us feel that the clinical trials in COG are not only clinical trials to look at new treatments and try to figure out what's best, but we also consider them pretty much to be the best care, the standard of care, and it's a guideline for all the institutions in the United States to follow who are members of COG. And certainly in Memorial and Sloan Kettering, they also have clinical trials that they do within their institution that also has the same standards. It's just they're asking different questions.
Dr. Cohen, it's true as long as you assume that they're following current COG protocols.
Yes.
That may not necessarily be the case, and that's where you have to be aware of that.
No, as I said, I think that the wonderful thing about pediatric oncology is that we have developed this collaborative network because, thank goodness, pediatric cancer is rare, and the only way we can study hundreds of patients and conduct randomized studies is with this kind of collaborative network. The vast majority of institutions do participate in COG, and you're absolutely right. There certainly can be certain institutions that, for whatever reason, don't, or there may be families that don't want to participate on a clinical trial. But it's a roadmap, or it's an outline of what is considered standard of care, at a certain period of time.
So I guess just to make a comment, even for Memorial, where we don't do transplant now, we still harvest stem cells after 3 cycles in every patient, and we do look at minimal disease in these stem cells. So I think that again, just emphasize that just not to jeopardize, we don't jeopardize anyone in terms of chances or whatnot. So I think it is a good practice to harvest early and to put it away. And I think the idea is to make sure that the participating institutions and the COGS actually doing the right thing.
I was wondering if you could explain or theorize the difference in the nature of the disease between early relapse and late relapse, and why often you'll see prolonged response with later relapses than you do with early relapse?
Well, one thing I think we learned over the years is that neuroblastoma in adults are very different disease from children. And this is sort of extreme. As the child grows older, we always wonder whether the disease actually changes. The question is seed and soil. Same seed, but at a different soil, the disease actually might change. So again, coming back to ask your question, we will be dealing with two different types of biology now that the child's older, even though it's the same neuroblastoma. I think that's something obviously I'm speculating, and I have no proof, but I think that sounds like this is what's going on. In adults, for example, neuroblastoma tend to be much more slow-growing, indolent. They tend not to respond as fast to chemo, but they also don't return. Sometimes they could, 10 or 20 years to come back. So this is sort of the spectrum. As you go from the younger child to the older child, the disease changes. And I think for those who relapse late, the fact that the child's older now, the disease actually probably has a different biology.
I have a question about the MIBG procedure. It's come up a couple times. I know Dr. Cohn had mentioned this as a MIBG therapy. My son has had 2 of these procedures done really as a diagnostic tool to make sure that the cancer was indeed not there anymore. But did I misunderstand? Is it actually used as a therapy as well? And could you elaborate at a high level for us?
Sure. So we are studying this. I don't know if Greg wants to make a comment. Greg is running the trial. Yeah.
There'll be a whole talk on MIBG therapy, MIBG transplants at 3:45 today. Happy to take questions.
It's basically the same thing as what you use for MIBG scans. It's just hooked to higher amounts of radiation. So it's a way of giving radiation directly to the tumor, but Greg will explain in detail.
This may be redundant, but I'll ask it. Can all of you or one of you speak to the process by which something goes from relapse therapy to frontline? And maybe put it into sort of quantify it. I guess maybe what I'm asking is that I don't really understand what a phase 1 or phase 2 or clinical study means in terms of a time frame for when my son might expect to gain access to a certain type of treatment. And it seems like you've all made the point that there's in fact lots of activity and options for relapse now, but it doesn't seem like frontline treatment is necessarily innovating the same way. And so what is the process by which something gets incorporated into frontline treatment? And if I can just give an example, or a couple, I sort of hear about antibody treatment, or I hear about vaccines, and when you go to pursue those, my son has just completed transplanted, or is completing transplanted his EME, and so you pursue those to say, well, I want to also get that, and they say, well, it's only for relapse patients, it's not for AD patients. And so, yet there's this philosophy that's sort of stacked up, as you say, cure up front everything you can. So how do we work that balance, and how do we get our foot in the door to these other avenues if they're not, if the door's not open?
Okay. So first of all, let me just back up for 1 second and tell you that a phase 1 study is largely done to look at dosing and toxicity. A phase 2 study is done to largely look at response. And then the phase 3 studies are usually done on newly diagnosed patients, whereas phase 1 and phase 2 are done in the setting of relapse to explore the activity of a new drug. We have moved drugs from the relapse setting to the upfront setting, and I'll give you a couple examples. One is topotecan and Cytoxan. We used that combination in the past in the setting of relapse. We saw very nice activity in the setting of relapse, and so in our new phase 3 high-risk COG study, we've now incorporated topotecan and Cytoxan in induction. There's a example of something we moved from the setting of relapse where we saw activity, we know what the toxicity is, and we've moved it up front. The antibody therapy also, which was spearheaded by the Sloan Kettering group as well as others in the COG, also showed very nice activity in the setting of relapse, particularly when there was more minimal disease, bone marrow disease, that type of situation. And we are now testing that up front in newly diagnosed patients in the COG in a randomized fashion. So patients who are following their transplant, who don't have any evidence of disease, are eligible to enroll on our study where you're getting randomized to either receive retinoic acid and antibody or no retinoic acid, or no antibody. And we will see, hopefully in a couple of years, we'll unblind the study. Right now we don't know what the results are, and we'll see if adding in the antibody to the retinoic acid regimen following transplant makes a difference. And if it does, our new protocol will be to have all patients receive, the antibody, retinoic acid, and then we'll add yet another drug. So little by little, the drugs do get moved into the upfront setting. They have to be proven first in the relapse setting, number one, to test their toxicity, to learn about how to properly dose them, and to learn if they have activity. And then if we can demonstrate response in the setting of relapse, clearly the goal is to move those drugs up front to hedge our bets that we can cure more patients when they're initially diagnosed.